of a 56-year-old female Caucasian, which shows a positive family history for neoplasms. The patient's mother was affected by breast cancer and the patient's father by a non-Hodgkin's lymphoma. The patient was treated in 2002 for a right breast cancer with quadrantectomy and radiotherapy. In January of the current year, the patient underwent a laparoscopic cholecystectomy due to microlithiasis and a gallbladder polyp. The patient is a smoker. She smokes 7 to 8 cigarettes per day, does not consume alcohol, nor she is a diabetic. The patient showed a significant weight loss of 14 kilos in the 6 months. In July 2013, the patient started reporting abdominal pain, which was occasionally radiating to the back and was only partially responsive to analgesic therapy with oxycodone and paracetamol. In March of the current year, the patient was admitted to another hospital where she underwent blood neoplastic marker screening, which resulted negative. At CT, there was evidence of a hypodense focal mass immediately posterior to the pancreatic body, which was determining stenosis of the splenic vein and only partly surrounding the superior mesenteric artery. Such lesion was deemed suspicious for neoplastic origin. Endoscopic ultrasound and fine needle aspiration of such lesion showed a non-diagnostic cytology. Also, a transabdominal ultrasound-guided pancreatic biopsy was performed, which again revealed a non-diagnostic cytology. The patient is scheduled today for a pancreatic endoscopic ultrasound for evaluation and fine needle aspiration, which will be performed by Dr. Petrone and Dr. Softiu.
So we are with the scope in the second part of the duodenum. We are looking for the head of the pancreas. You see the mesenteric vessels here, the artery and the vein, and the head of the pancreas here. And the aorta. So this is the uncinate process. We are looking for a small lesion and we see here an hypoechoic solid lesion, not too big, just between the vessels. So you see the mesenteric vein. Okay. No, thank you. And the superior mesenteric artery here. This is the lesion that we are going to biopsy, or we try to biopsy now.
Let's say the sonographic impression is, what can you conclude from it?
From sonographic findings, I would say that is an epithelial tumor, an adenocarcinoma. It's a solid tumor, hypoechoic, with irregular borders, just close to the vessels. So I would say that it is an adenocarcinoma. We can check with elastography.
Yeah, so it's pretty easy. We just press a button. So now you already see the image. So you just have to keep the scope still and rely only on the pulsations. So then if we freeze one of the images, you can also look, you have a curve of the compression rate, so you just have to keep the image still. And if you look at this image, of course there are some artifacts here because there are some vessels in the elastography image, but you see that it's really hard. And of course you can also measure this kind of information, so you can use strain ratio. We don't have strain histograms installed in the system here, but we can use the strain ratio and actually get some sort of semi-quantitative information. There are various ways to do it. In one of the studies they used two regions of interest, one at the same depth, so something like that. And you see that the values of the strain ratio are 7.54, so it's pretty hard. So you can use elastography. You see it again, it's a bit difficult for elastography because it's a profound lesion. It's towards the 3-4 centimeter limit, but nevertheless you can see, and you can change the elastography region of interest to avoid some of the vessels, and then you can try to get better images. So you need to have some patience, but it's pretty quick, so you can get some answers in a few minutes. And we have discussed already, because the patient has two negative fine needle aspiration procedures, one endoscopic, the other one transabdominal, as far as I understood. We will probably do a third one, but we thought that contrast would be really important for this patient because we can get some more information after elastography and contrast. So if Mara agrees, we can switch to
perform,
contrast.
yeah.
And
Some of you.
so some of you, we need a specific contrast imaging mode and then contrast. And can we twist
Yeah,
it
sure. It's
left,
already
right,
checked. Yeah,
or
it's already right.
yeah, it's okay. I'm fine with that, but you have to. It's the image now. It's twisted left, right, but we can leave it like that. So you have to look for the tumor mass here.
It's okay.
Okay, and now you already see the contrast, so it's already in. That was pretty fast, and you already see it through the superior mesenteric artery, but you don't see it in the tumor mass. So this is still hypovascular. And now, if you wait a bit, now you see the contrast in the venous phase. So in the after 30 seconds. So now it's already in the superior mesenteric vein, but you still don't see it in the lesion. So the lesion is hypovascular or hypoenhanced. That's a bit more correct. So it's hypoenhanced in both the arterial phase and also the venous phase. You probably recall already that there are only two phases for the pancreas, one arterial and one venous, as opposed to liver examinations. But you see that it's hypoenhanced, so this is really important. There are some vessels here, small vessels, so if you let's say zoom in on the lesion, you see that there are some small microbubbles flowing through the lesion because it's a solid lesion. It's not cystic, it's not avascular. So there are some small signals inside a lesion, and if you use the MTI mode, the microbubble trace images, that you see that there are some small vessels inside a lesion, but on the whole the lesion is hypoenhanced as compared to the pancreatic parenchyma. And this is really important because we have the elastography, which tells us that the lesion is hard, or it's a low strain lesion, and we have the contrast, which gives you information about the vascularity. So based on the currently published data, in 95% of the cases, this is how an adenocarcinoma performs.
Yeah.
So as Mara said before,
Okay,
we
this is
pretty
an
know for
excellent,
sure.
excellent demonstration with the synchronous flow in the arteries and venous system. So
always
we
nice
are
when
waiting
there
for
are-
your
yeah.
puncture now.
Okay, so Mara will switch to, we can
Yeah.
switch back
So,
to the,
Dr. Savtoyo, you said it's typical for adenocarcinoma. You think it could not be a metastasis of the breast cancer?
well, yeah, that's of course, it's a discussion. Metastases can have similar aspects, but usually they have a peripheric vasculature. So of course we will still need the FNA results, but at least we know it's a malignant lesion, so we know that for sure it's not benign.
So we have here the lesion. This is the superior mesenteric artery, just close to the lesion. And now we try to perform FNA with a 20 gauge needle.
What kind of needle you choose for this
It's a
case?
standard 25 gauge needle. You see the tip of the needle there?
Okay.
I would say we are inside the lesion now. And we perform the capillary technique. Un po' più piano. And let's hope that this time is a good time. Wait. Okay, I think it's enough. So the problem is that the lesion is close to the superior mesenteric artery. She's a young woman, but I think that she will undergo neoadjuvant therapy. What do you think, Adrian?
Yeah, it's a difficult decision, but even if the FNA comes back negative, then based on elastography and contrast, I think she might be offered surgical intervention. It's not a clear-cut encasement of
The artery.
superior mesenteric artery, so maybe, I mean, it's borderline resectable. Of course, it's close to the superior artery and mesenteric vein, but it depends what the surgeons find and if they can take all the tumor mass with the pancreatic head. So it's going to be difficult, a difficult question. But being a young patient, she might be offered a surgical option, I think.
We go for a second pass, I think.
And it's always a question of how many passes we will do, but we are lucky that we have cytopathology inside the room.
Yeah.
So we'll hear the results pretty quick while doing the second pass. We usually do 3 passes, but whenever the cytopathologist is in the room, then we can decide to do more if the lesion is still, if it's still not clear what's in there.
Puncture is not easy in this case. You have a long route.
Yeah.
Yeah.
It's a difficult position, and also with a 25 gauge needle, probably the probability of getting microhistology and cell blocks would be lower. So the differential diagnosis in between a primary pancreatic adenocarcinoma and a secondary lesion, secondary metastasis would be quite difficult. So unless we get microhistology, and it's not so frequent to get that with a 25 gauge needle. On the other hand, the puncture here would be really difficult with a 19 gauge needle. It's a long route, so
for this position, yeah, I would say that 25 is the best
it's
needle.
the optimal.
Yeah.
Yeah.
We are performing the second passes. Okay. Professor Doioni maybe is ready for the first pass.
The material is scanty, but I think is sufficient for diagnosis because you see in this field there are some normal pancreatic components, some acinar cells, but see this group here with atypical epithelial cells. I think also it could be quite problematic, but I think is primitive of the pancreas, so adenocarcinoma of the pancreas.